Hi, this patient is a 60-year-old female suffering from both knee pain for last 10 years. The fear of surgery kept her away from making the surgical decision for last 8 to 10 years. So when she met me, I counseled her why a knee replacement surgery is important, how much quality of life it changes once the surgery is done. So I told her the benefits of robotic knee replacements. I told how a imaging and a non-imaging robotic system works. What are the advantages of CT-based robots, which I use in a regular way. So in the CT-based robots, we do the CT scans before surgery. Once we decided to go for the surgery, we got a CT scan, did the CT scan, planning preoperatively, then took her for the surgery and successfully completed the robotic surgery. So now I'm going to show how do you pre-plan for the patient for the surgery. So we get a CT scan. The CT is made from hip, knee and ankle. There's a protocol to do CT which can be established in the institution. Once the CT is done, it gets loaded on this computer or the software, and then there is a demarcation of the soft tissue with the bony windows, that is called segmentation. The CT, once it is loaded on the computer or the software, the segmentation is a process of delineating the bony and the soft tissue boundaries, and the areas of interest for the surgeons are shown. So this segmentation is done by the software itself. Surgeon need not worry about this part. Once the CT is done and the segmentation is done, then if you see on the screen, there are 4 parts. One is a coronal, one is a sagittal, 3D, and then an axial sections. So all 4 parts are there in the same screen, and then the surgeon starts marking the joint. First he marks the hip center. If you see, there is a hip center, all 4 planes you can see. Then there is a condylar center. Condylar center is basically the knee center. There's a coronal, there is an axial, there is a sagittal, and there is a 3D. This head center, the hip center, and the knee center is for the mechanical axis of the femur. Then there is a medial epicondyle. You can take the highest point of the sulcus. Sulcus is the best point to take because it defends the surgical transepicondylar axis. Then you mark the lateral epicondyle. So the medial and lateral epicondyle becomes your transepicondylar axis. The medial posterior and the lateral posterior, these two axes are for the posterior condylar axis. Then there is medial distal and then the lateral distal. This is for the varus valgus of the distal femur. So to be precise, hip center, knee center for the mechanical axis, two epicondyles for the transepicondylar axis, two posterior condyles for the posterior condylar axis, medial and lateral distal condyle for the varus valgus of the distal femur. Once you are with the femur axis, then you go mark the tibial axis. Now for the tibia marking, the tibial center, the center of the tibia can be taken between the two spinous process. Then the ankle center, that is the talus center for the mechanical axis of the tibia. Tibial tuberosity, medial 1/3 of the tuberosity, and the PCL attachment for the rotational points for the tibia. Medial condyle of the tibia, and the lateral condyle of the tibia for the varus valgus of the proximal tibial cut. Once this is done, then we do something called registration point of the femur. Again, medial point. Then there is a lateral point, then there is a distal notch point, then there is an anterior point, then there is an anteromedial, anterolateral, posterior point, posteromedial, posterolateral. These are just the registration points. Then we make the tibial registration points, tibial center, lateral point, medial point on the tibia, tuberosity point on the tibia, anterior point, proximal medial and proximal lateral. So these are the registration points. So once you go ahead and mark the patient's knee, first you mark the femur registration, tibial registration, then it generates any error you have marked on the femur on the patient's knee gets compared with the CT scan. So these are the advantages. Once you have done the femur axis, tibia axis, femur registration, tibia registration, then you go and select the implants. First you size the femoral implant. How do I size my femoral implant? First, if you see in this section and the anterolateral surface, I put my implant. So this is the anterolateral surface. Once I am okay with this, then I see how the implant behaves posteromedially. This is posterolateral symmetry, if you can see the implant, and then the posteromedial symmetry. You have three things which can happen in the posterocondylar offset. Either you can match in some implant the posterolateral condylar offset. In some implants you can match the posteromedial condylar offset. So option one is match the posteromedial condylar offset, accept a millimeter or two overhang or the implant shooting out of the posterolateral boundary, acceptable. Option 2, match the posterolateral condylar offset, maybe a millimeter or two underhang in the posteromedial condylar offset. Option 2. Option 3, match both the condyles, medial and lateral condyles, which can be option 3. Any of the three options can be seen. Once you choose the anterolateral surface, then the posteromedial, posterolateral you'll see. Then you see how much it's cutting posteriorly in posterolateral and posteromedial. Then you see how the implant fits in mediolaterally, that is on the distal surface. Then you go on to the 3D and then see how the implant fits in mediolaterally, anterior surface, mediolaterally, distal surface, posteromedially, whether there is an underhang or overhang. And this is how you basically map the femur with or shape match the femur with the implant. And this is the advantages of the image based robot. Then you come on the tibial section. In the tibial section again you see how the implant is sitting mediolaterally, anteroposteriorly, and then once you make the decision that this is the implant which fits properly, then you go ahead with the final plan. And then once you make the final plan, you can command that this is the approved plan. Once you approve, you see it all turns green, and then it shows what is your distal, lateral, distal, medial, distal cut you're taking on the femur, posterior cut you have planned on the femur. Then what is the component in the sagittal plane, whether you flexed or extended the component. In this case, I have taken 3.2 degree external rotation to the posterior condylar. My distal cut is 0 degree to the center of the hip. Then my lateral cuts and the medial cuts on the tibia is seen. The slope which I have taken is seen, and then how much varus I have given on the tibia, and then what is my final hip, knee, ankle hip knee ankle axis pre and post-operatively shown. So these are the advantages of image post robot. Once this is done, the saved pen drive, then you save this data, and the taken in a form of a pen drive gets loaded on the robotic machine. Surgeon goes into the theater, does the surgery, compares the points which he has marked on the CT on the patients. Then error is generated. If is an acceptable error, you can continue with the surgery, and then you can, this whatever plan you do is a static plan. You can go to the operation theater, you can change everything. You can change the component up down. Suppose if I have chosen a size D, I can put a size C femur or a size C E femur. If I have chosen a 2 tibia, I want to do a 3 tibia on the table, I can do. So all these things you can do, and you can also change the component flexion extension. You can move the distal cut up down. You can move the femoral component anteriorly, posteriorly, and this is the planning for you.
Good evening, guys. So today I'm going to demonstrate the right knee surgery. This will be done through Misso robotic system, which is a fully automated robotic system. I have done the CT markings before the coming into the operation theater. I have marked my points on the femur and the tibia. I have taken D femur, and I will see how it goes about once I do all the CT markings. Then I will show you the gap charts, any intraoperative variations, how the system maneuverability is there. So it is just a static pre-plan what I have done. I can go inside always, I can change the points, and I can change my plan. So the plan is not rigid. The plan is only to come inside the theater to upload the pen drive onto the system. So let me start marking now. I'm a medial parapatellar guy, so it's a midline incision, medial parapatellar arthrotomy done. Entry on of both the medial and lateral meniscus has been removed. I kept the PCL intact. I will see once I go in whether I should do a CR or a PS knee. I do both of them. So let me start with the markings. Okay. So I'll mark the points on the femur first, and then go with the tibia markings. Yes, please. So the first marking, if you can see, it's medial epicondyle. The second marking is lateral epicondyle. Yes. Then is the center of the femur. Yes. Anterior point. Yes. Then the posterior point. Yes. Then the anteromedial. Yes. Anterolateral. Yes. Then you have the posteromedial. Yes. And then you have the posterolateral. So these are called initial registration points. This is to know that initial registration points, how my initial errors of marking. So we have to get it less than 10. The idea of less than 10 is that our initial marking is over. You can just see everywhere how your initial marking is done. Now I go for something called final marking, that is many more points on the femur. Yes, please. So now I am marking distal medial. Yes. 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 So it's a varus knee. If you see on the medial side, it's a bare bone. So I am touching the bare bone because the cartilage is not there. Wherever there is a cartilage, you pierce the cartilage and go inside the bone and mark. Now I am marking the trochlear surface. Yes. 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 Now I am marking the distal lateral surface. Since it's a varus knee, if you can see here, the lateral compartment, our cartilage is not so aburnated, so I have to pierce the cartilage and go inside the bone. Yes. 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 Now all my femur markings are done. It shows a final error, what I have planned on the CT and what I have marked here. And depending on the error, I will see anything less than 1 is okay. 0.5 is good, less than 1 is absolutely fine. So now I go ahead with the markings. These are called the verification points. Yes. These verification points are indirectly when you move the limb from flexion to extension. Once you take this, yes. Once you take these verification points, basically those points are enough. Yes. The other points are auto calibrated by itself. So now we had an initial RMSE, we had a final RMSE. Initial RMSE was less than 10, final RMSE was less than 1, and the 3 verification points were touched. These verification points every system has different ways of verifying. Some have pins or buttons which are loaded on the femur and the tibia to verify. In this system, these points, there is no extra metal wear to touch, so that you can touch these points automatically. The other points are calibrated on the femur. Once we do the tibia, the same points will be taken for the tibia as well. Now I go with the tibia marking. Now again, in the tibia, the sequence is same. Yes, initial RMSE and then going for the final RMSE. Yes, yes, yes. So basically I marked medial side, lateral side, tuberosity, anterior point. Now I am marking, yes, medial surface, articular surface and lateral artificial surface of the tibia and the ACL footprint. Yes. So now this again goes for the initial RMSE. It should be less than 10. Now we are at 7. That means we are good to go. Now we go and mark more points on the tibia. Yes. 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 Again, it's a varus knee, medial side cartilage is gone, so I'm touching the bare bone. Wherever the cartilage, I'm piercing it. Now we are marking the interspinous process. Yes. 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 Now all the marks on the tibia is done. It shows the tibial verification how it is. Again, less than 1. Anything less than 1 is highly acceptable. Now femoral, the markings done, tibia marking done. In tibia again I have initial RMSE, final RMSE. Now the verification points on the tibia. So now let me go for the gap check. So till now we have done the verification point. This is to fit to the system that what we have marked on the CT versus what we have marked here. The points have got confirmed. Now it's a time to check the gap. Now hip, knee, ankle axis, it will show how much is the deformity, and then it will show what is the medial side tightness, lateral side laxity. It's a first we'll check what it is. If you see on the screen now, so my planning was distal medial is about 3.4 and distal lateral 3.4 and distal medial is 6.6 and proximal lateral is 8.6 and proximal medial is 4.6. Proximal means tibia cut. I have planned on the lateral side 8.6, medial side 4.6. On the distal lateral it is 3.4 and distal medial is 6.6 on the femur. So it is generating a gap of 5 and 4 or basically 4 and 4, and this is the gap which is generated. Now I see what is the deformity. If you see that F bar E, that is the flexion extension. The sagittal deformity of the knee is, it's almost a neutral knee. If you can see, this is without stressing, almost it's a neutral knee. So we are basically, the sagittal deformity is 1 to 2 degree of flexion deformity, and it's a varus 0 degree. Now I am trying to give the valgus stress and seeing medial side. If you see on the screen, it's opening 5, lateral side is 4. If I leave it without stress, it is 4 and 3. If I give a varus stress, it is again 6 and -1. That means it's opening more on the lateral side when I give a varus stress, and on a valgus stress it's opening very minimal on the medial side. Now the deformity is 2 to 3 degree sagittal deformity, varus is 0 to 1 degree. On the tibia, on the initial plan itself, I have given a 1 degree tibial slope, 1 degree varus on the tibia. So on the slope is 5 degrees. Now I'll check the knee at 30 degree. Again it is 5 degree varus. I am giving a valgus stress. So the opening on the medial side is good. Again, if you see the gaps, what was in extension was 4 and 4 or 5 and 4 is becoming, again it's 5 and 5. Again it is 8 and 6. Again it is 9 and 7. Again it is 9 and 7. Again it is 9 and 7. That means my flexion is little bit looser than extension. And again it flexion at 90 degree. I give my gap check and see capture. So if you see with the valgus stress, I am getting 10 on the lateral side, 6 on the medial side. Again on the extension with full valgus force, I am getting 4 and 4 or 4 and 5. Check capture. So now here I have a scenario where my extension medial is 4, extension lateral is 4, flexion medial is 6, flexion lateral is 9. So now we are having a flexion gap which is little bit looser than the extension gap. Now I'll have to either increase the distal cut and match the extension gap by match the flexion gap by increasing the distal cut, or try to see whether I can get down the flexion gap somehow. Okay, distal anti-femur implant, femoral shift. Now I am increasing my distal cut by a millimeter or two, distal 1 mm up. Yeah, one more. Finish. Close. Femoral shift again. Femur close. Close. Femur shift. Femur rotate. Sorry, femur rotate. Close. Close. Rotate. Flexion 1 more degree. Okay, finish. Close. Since I have given a flexion of 3 degree femur implant, I am going to shift my component 1 femur implant. Femoral shift. Anterior 1 mm down. So now you see now my extension gap. Check pa? Check. Gap check. So now you see my extension lateral is 7, extension medial is 6, flexion is medial is 5, flexion lateral is 8. Since I am planning for a CR knee, my concept is in a CR knee I keep my flexion 1 loose than extension because of the PCL which I try to retain. If I am doing a PS knee, I try to keep the gaps equal on the lateral side. But since I am doing a CR knee, I'll keep my flexion 1 loose than the extension, because I always feel in a CR knee it's better to keep flexion little bit loose so that post-operatively range of motion is better and they get good physiotherapy protocols. So now tibia, I'm shifting the tibia up, yes, by 1 mm. Yeah, that's enough. Now this is my plan. If you can see what all I did, close. So now femur implant. So if you see the femoral shift, see these are the options if you have on the femur. You can proximalize the component, distalize the component, shift the component posteriorly and anteriorly. So these are the 4 movements if you have on shift basis, where you can have up, down, distal 1 mm up or 1 or 2, whatever it is, and distal down, then shifting the component anteriorly and posteriorly. Close. Now femur rotate. Now you can, if you want, you can give your varus, distal femur 1 degree varus or valgus, and then you can flex that, extend the component, and you can play the rotation. So the whatever you have planned on the CT and pre-plan, you basically shouldn't be that you follow the same. You can come back and always change the plans. So this is the flexibility of the system. In the femur, you can rotate, you can give the varus valgus, you can flex extend, and also shift the component up, down, superiorly, inferiorly, and also anteriorly and posteriorly. Now close. Tibia. Tibia. Yeah, tibial shift. See, in tibia also you can shift up and down. For example, if you want to tighten both flexion and extension space, you can tighten the tibial by reducing the tibial cut. You can tighten both, or by increasing the tibial cut, you can, if your flexion extension is tight, you can loosen it. Close. Tibial rotate. Yes, for the guys who believe in functional alignment or the guys who wants to do mechanical, the system is okay for both the mechanical, functional, or altered mechanical. All three philosophies can be followed. See, by giving the varus on the tibia now, suppose I give couple of degree varus on tibia and couple of degrees on the distal femur, either I fall into the functional or the altered mechanical pathway. So whichever philosophy you use, you can follow. You can do mechanical, you can do altered mechanical, you can do functional, all three. Kinematic is a different philosophy altogether, but still you can go ahead and do kinematic on this. And even if you are an inverse kinematic guy, you can follow the inverse kinematic philosophy. Basically, I am somebody who starts as a mechanical guy. On the table, I decide depending on the tightness of the tissue, whether I should jump into a functional or stay mechanical. Here I have given 1 degree of varus to the tibia, and I have not altered anything else because the gaps are almost matching to each other. Now I'll go ahead and give the robot the order to cut. This is the base support where the robot also becomes static. So the position has been locked. So now there is an irrigation saline which constantly irrigates the when the robot is cutting. So let's start cutting the distal femur now. Now enter chamfer is finished. You can have a smaller incisions and retraction as per the cut demands. Now it's doing the enter chamfer. Posterolateral chamfer. When the posteromedial cut is done, again if you see, once all the cut is done, there is enough boundary of bone which is left both on the medial and the lateral boundary. Pathway of the which is seen, the red color pathway on the screen is the pathway at which the robot will take and cut. And if you see, once it starts from the anterior part, the cut is bigger. The moment it goes posteriorly, that cut becomes smaller. This is to accommodate the bony boundaries and not to violate the bony boundaries and go more medial where the soft tissues are. That's why the pathways are set in such a way that once it goes into the area where the critical soft tissues are there, the pathway is shrunk in such a way that it does not breach the bony boundaries. Come this side also. Chuck. Chuck. This you can release it or you can leave it like that's balanced. Okay. Start mixing. So it's been 6 to 8 months for me to start using the Misso robot. I have been actively involved in the development process of this robot. Misso robot is safe, it's active, it's city-based, mill-based, dynamic joint balancing. Its footprint is quite small.
What truly sets Misso apart is its capacity to tailor each surgery to the patient's needs. Its real-time intraoperative measurement along with sophisticated point-to-point mechanism and real-time intraoperative measurements.
We feel that any innovation, any collaboration, anything that we learn can be brought to the market relatively faster, sooner, and make sure that we hear the customer insight. We do not believe that innovations happen in an engineering lab. It happens right besides the doctor in his OR. That is how we have developed Misso. We have spent time and energy in making sure that we create a collaborative environment that gets us the best knowledge from the industry to be executed by our engineers that we have created at a large scale to execute a program which is truly future forward.
Misso elevates standard of orthopedic surgical procedures, offering a level of customization and precision which is unparalleled.
I congratulate them for getting this new robot, and it's a wonderful opportunity to feel good as it is an indigenous product and made with lot of efforts, which is efficient, meeting the global standards, and which is affordable.